Hi, this is Andy Beamer. I'm going to be talking to you today about preoperative evaluation. Pre-op evaluation is not the same as pre-op clearance. In fact, there is no such thing as pre-op clearance. Rather, what we have is a preoperative evaluation in which we look to balance the benefit of the procedure and the risk of the procedure. Risk, in turn, is a combination of procedure factors and patient factors. Pre-op testing, to the extent that it is useful because it helps us refine our estimate of the risk that the patient has for the procedure, not that the preoperative testing in and of itself is something that determines whether the patient can have the procedure or not. Certain types of procedures are inherently high risk. Intrathoracic procedures, intra-abdominal procedures, major vascular procedures are all inherently high risk. The risk of surgery can be increased if the surgery is done on an emergency basis. On the other hand, there are certain situations, such as performing a procedure in an ambulatory care center, which would make us be less willing to accept risk. Some procedures are so low risk that it doesn't make any sense to do any testing at all under any circumstances. The procedure is just such a safe procedure that almost no matter what the patient's condition, you can go ahead and approve them to have the procedure without any further testing. Cataract surgery is a great example. Although you shouldn't delay the treatment of a heart attack in order to pause and have your cataract surgery, you can in fact have cataract surgery almost no matter how sick you are from a cardiac perspective. Likewise, some patients are extremely low risk. This is a sign supposedly in front of a day surgery unit in the UK. There's no lift. Use the stairs. If you can't make it to the fourth floor, you're not fit for day surgery. Please contact us on the phone. So pre-op functional status is one of the patient characteristics that will help us understand the risk of surgery for a given patient. But like many of the other factors that contribute to risk, it is not something we're likely to be able to change at the last minute, just as we can't change their age, medical history, or other problems. So the real purpose of pre-op testing is to help us refine our estimate of perioperative risk. It's not really to take the place of all the different things that we know that contribute to that risk. And the purpose of all this evaluation is to help us determine if the risk can be modified by changing the patient characteristics by, say, optimizing medical therapy, or on occasion deciding to send them off for coronary revascularization, or changing the procedure that we decide to do, perhaps doing a more limited procedure, or deciding to do it in the hospital rather than the ambulatory care center. You'll note that nowhere on the list of factors to be considered for determining the cardiac risk of non-cardiac surgery do you see the electrocardiogram listed. The electrocardiogram can help you understand whether one of the underlying problems is stable or unstable, but it's really the underlying problem that is the issue, not the status of the electrocardiogram. Quoting from Up to Date, the electrocardiogram abnormalities are not part of the revised Lee index because of the lack of prognostic specificity associated with these findings. That doesn't mean that preoperative electrocardiograms are useless. Having a pre-op electrocardiogram can be really helpful if there is a post-op problem. As you know, changes in electrocardiograms are far more specific for a problem than the absolute appearance of an electrocardiogram. Having an electrocardiogram that looks significantly abnormal preoperatively in the setting of other problems may make you more suspicious that that problem is not as stable as the patient is letting on. But they really need to be interpreted as part of the clinical story and in the light of the known problems that the patient has. So let's go over a few abnormal electrocardiograms. My least favorite line on the entire ECG report is the line that says either normal or abnormal, because so many different things are labeled abnormal that really don't have a whole lot of meaning. This is perhaps an example of that. This is an electrocardiogram that was read as showing cannot rule out anterior wall myocardial infarction. The only real abnormality here is that V3 doesn't show as much of an R wave as we would normally like to see. It's the same or maybe a little bit less than V2, suggesting a loss of forces in the anterior wall of the myocardium. This could be from an old anterior infarction, or it could be a matter of so-called lead placement. This electrocardiogram is similar, but perhaps a little more extreme. The precordial leads show Q waves in V1 and V2, and not a lot of R wave in V3 relative to the total size of the QRS complex, and for that matter, that extends over to V4 as well. This could be from an anteroseptal myocardial infarction, or given the findings of left ventricular hypertrophy on this electrocardiogram, it could be just that the heart is a bit large and the anterior leads are not reflecting the same location on the heart. These are just examples of a generalized problem. The precordial leads are placed across the chest from the right side of the sternum around to the axillary line on the left. Even if the leads are placed properly by surface landmarks, they may be placed very, very differently related to the position of the heart inside the chest. This can be true in people who are thinner or heavier. This can be true in women who are large-breasted. This can be true if the heart is just slightly lower, slightly higher in the chest. On the CAT scan on the right, we have an example from a large-breasted woman. You can see that the heart is not anywhere near the surface of the skin, and the leads placed quote-unquote properly on the surface of the skin may be very differently placed than they would if this were a small-breasted woman or a thin man. Let's shift gears for a bit. Here is an electrocardiogram showing nonspecific ST tube abnormalities. This electrocardiogram has just a bit of ST segment sagging throughout everywhere, but I guess mainly in the inferior leads 2, 3, and F, and then lateral leads V4 through V6. The reason we call it nonspecific is because it's nonspecific. We don't really know what this is telling us other than we can't put it in a textbook as an example of normal. Here's another electrocardiogram with nonspecific ST tube abnormalities. There are some T-wave flattening, especially in 1 and L and across the precordium. While this may point us to some electrolyte abnormalities, it may not point to much of anything and is not necessarily going to be very helpful in deciding whether somebody is suitable for surgery or not. Yet another type of electrocardiogram that we see that is another non-abnormal abnormality is the incomplete right bundle branch block, or right ventricular conduction delay. You can see that there's an RR prime pattern in lead V1 and a bit more R wave in V2 than we would normally expect to see. This may represent a little bit of slowed conduction on the right side of the heart, but the reality is even if it does, it doesn't really mean a whole lot. And actually sometimes you can make this abnormality appear or disappear just by moving the right precordial leads V1 and V2 up or down an inner space or so when you're doing the electrocardiogram. On the other hand, sometimes the electrocardiogram can help us understand what the patient is trying to tell us. This particular gentleman had some chest discomfort, and as you got more of a history, it sounded like exertional chest discomfort occurring at relatively low levels of exertion. The EKG has significant abnormalities, in particular in the anterior precordial leads. The T waves go from upright to biphasic to flipped, suggesting ischemia from the mid-LAD territory, the mid-anterior wall, to the apex. And in fact, that's what this gentleman had. He had a very tight lesion in his mid-anterior, in his mid-LAD, feeding the rest of his anterior wall. So once again, pre-op evaluation is not pre-op clearance, it's pre-op risk assessment. And the risk assessment consists, again, of looking at the patient, predominantly looking at their underlying history and their medical problems and the stability of the medical problems. The testing is really used just to help you understand whether those underlying problems are stable or not. Likewise, you need to look at the procedure and consider how big is the procedure and consider whether the benefits of the procedure are outweighed by the potential risks. If the patient looks like they're particularly risky, you may consider whether the venue of the operation should be changed or whether the operation should be changed and limited in some way. One way or the other, you're always balancing the potential benefit and the risk of the procedure. So you're not on your own if you're struggling about what to do with a patient. We're glad to help you out. We're glad to see any patient in consultation if you think that you need a cardiology consultation to help figure things out. But a lot of times all you have is a question about an electrocardiogram and whether this electrocardiogram, among all the electrocardiograms you've ever looked at, is the one which is shouting out at you that you really ought to refer them for further testing. We're glad to take a look at it with you. Either call the person who read the electrocardiogram, call any cardiologist. If you call Berkeley Heights, there's always somebody who's assigned to be the quote-unquote unassigned doctor who is supposed to be answering such questions. I know the folks in the ambulatory care center in Berkeley Heights often will walk down carrying an electrocardiogram saying, hey, is it okay for me to go ahead and put this person to sleep? We're glad to do that kind of stuff. If you need a hand, give us a call. And I guess in general, if there's anything I can do for you, or if there's anything we can do for you, and or anything you think we can be doing better, please let me know. I hope this talk was helpful. I'll talk to you soon.